Hi, everybody. Good evening. Thank you for joining us. We're just going to let everyone trickle in from the waiting room, so we'll start in just a second. And hi, everyone. If you're just now joining, welcome. We are just going to give it a couple of just a little bit longer just to get everyone dialed in because it looks like people are still joining. All right, everybody, I think we're ready. Good evening, everyone, and welcome. Thank you so much for joining tonight's webinar. We're thrilled to have such a strong turnout tonight, and I'm excited for an engaging and educational session together. My name is Allison Lyon, and I'll be guiding you through tonight's program. I work with Kim at Dermatology Authority. Before we begin, we just want to thank you to our partners at Club Derm and the L'Oreal team. Their commitment to supporting educational programming like this is what makes tonight possible. So we truly appreciate their partnership. And just a few housekeeping items before we get started. Tonight's session will include live Q&A at the end, so please submit your questions in the Q&A box at the bottom. We will address them at the very end of the webinar, but you can submit them anytime throughout. A few questions have already come in. Yes, tonight's webinar will be recorded and it will be on the Club Derm page after. So we'll probably have it up about 24 hours, 48 hours from now, but it will be recorded and available for viewing afterwards. If you experience any technical issues, feel free to message us in the chat and we'll try to assist you right away. So now that housekeeping is completed, we are excited to introduce you to tonight's speaker, Mr. Kaufmann, Dr. Kaufmann. He has a very impressive resume, and I know that he does not need an introduction because I know you've seen his name everywhere. He's the former president of the AAD, the chief medical officer at Advanced Dermatology and Cosmetic Surgery, clinical professor at the Mount Sinai, and then a voluntary associate professor at the Department of Derm at University of Miami. And he sits as on two boards as director for ASDS and the Florida Academy of Dermatology. So with that, we'll hand tonight's webinar over to Dr. Kaufmann.
Okay, thank you, Allison, and thank you everybody for joining us tonight. What I'm going to try and do tonight is go over the updates for 2026, and actually we'll talk about updates that are as recent as yesterday. We really what I'm trying to do is lay out a landscape of where we are today in dermatology, where we're going, and how we probably need to start thinking outside the box in order to keep our doors open. So without further ado, I will begin. These are my disclosures, but they really don't have any impact on the talk tonight. So where are we? The need and demand for quality dermatologic care continues to grow and will never end. It is infinite, right? So people will always be coming in with skin disease and requiring our care. The only thing that's going to change and evolve is the way that we deliver this care. And so sometimes, dermatologists think that they understand and know the best way to deliver care. And most of us during COVID who dealt with telehealth felt that it just wasn't the right way to do things. But sometimes it's not up to us to make those decisions. Sometimes our patients are demanding that we see them in a different way than we're used to. And we have to be able to pivot and change and adapt with them. Inflation is now the greatest threat to the independent practice of dermatology. Probably something, the most obvious thing I'll say tonight, because you're probably all more than familiar with this concept. The conversion factor, and the conversion factor is this black box number that CMS comes up with. They multiply that number times the total RVUs of your procedure, and that gives them the physician fee schedule. So the RUC basically determines how many RVUs each procedure gets. And then CMS gives you the multiple to take on that RVU to determine what the reimbursement is going to be. And the conversion factor was higher 25 years ago than it is this year. And I know a lot of people have been touting the fact that we got a bump up this year, which we did, but the conversion factor was higher in 2023 than it is this year. So even with the bump, they didn't even get us back to 2023. So that's how bad things have been going in the physician fee schedule world. And then payers and pharmacy benefit managers are predominantly one and the same. Hopefully, that will change soon. There are some indications that the legislation that passed yesterday actually will start doing that to some degree. And so we used to wait till the end of the year for this bailout package that would be signed at the last minute before Christmas, usually, that just put everything but the kitchen sink in it for spending in the country. And in it would be some kind of what we used to call a fix, a doctor fix, which would adjust the conversion factor so that even though CMS said it would go down, it wouldn't go down that much or it wouldn't go down at all. And we've gotten very used to hoping that we just don't get a cut, but that's really not enough anymore. Yesterday, and this is a headline from today's AP, the president signed a budget bill that ended the shutdown and also had healthcare related details in it, which I'll get to near the end of this talk. But it is now something that we have to wait till the middle of the year sometimes to find out that what they're going to do to help us during the year that we're in. It used to happen in December. It's now happening in February. Last year it happened in March. And this one isn't really done because they didn't address the conversion factor in this bill. You probably have all seen this chart. This is a chart of the different stakeholders in healthcare, physician fee schedule at the bottom, the one that looks like it's flatlining, and then the inpatient hospital, outpatient hospitals, and the nursing facilities and nursing homes, and the CPI line, the consumer price index, which is the consumer determinant of inflation. There's another line, the gray line, practice costs or MEI, the Medicare Economic Index. That's the index that they CMS kind of fidgets with and comes up with a number that they think is more realistic to inflation for medical practices. The truth is, it doesn't matter which of these lines you use, we are clearly way below them. And there's other ways to look at this. This is just in tabular format. I told you in 2001. 2001 was actually our highest conversion factor at $38.25. It's never been higher than that. But that $38.25 is a hell of a lot more than the $33.40 that we're getting this year, even after that bump up from last year. And if you take inflation into account, you really see that in real terms, we are getting killed by inflation, over a 50% decrease in what we were paid 25 years ago, which is a crazy thing to think about if you haven't thought about it. Inflation just keeps going up. I mean, it is coming down now. This is a graph from 2022, but costs in a medical practice are not coming down, at least not in the practices that I've seen. This is a graph showing the blue line is the nominal conversion factor over the years, showing you that there's been a decrease in the conversion factor. And the gold line, the broken line, is showing you in inflation adjusted terms. The conversion factor is not really in the mid 30s, but it's actually in the high teens when you account for inflation. And this is from an article in Derm Surgery last year or the year before, showing different codes that are very important to dermatologists. The 17,000, the biopsy, excuse me a second. the incision and drainage, and the destruction in Mohs codes. And it's showing you that these codes in real terms have decreased over the last 20 years. And if this looks like we're falling off a cliff, we pretty much are. And the government continues to kick the can down the road. And eventually we're going to fall off the road if they don't do something. If you want some good news, there is some good news this year. And that was that the Office of the Inspector General looked at the modifier 25 use of dermatologists. And there was some nervous people when they started looking at this. But what they found was that out of 100 sampled E&M services, 90 of them were actually legitimate for modifier 25, which is basically doing an office visit at the same time as a surgical procedure. The OIG said, based on their results, there was probably an overpayment of about $63 million to dermatologists, and that CMS should do something about that. And they recommended to CMS to claw back that money, and also that they should do more education. And something that we don't see very often, CMS actually rejected their recommendations, and they said that they don't concur with the recommendations and they basically said that 90% is pretty damn good, and that they've already taken steps to promote compliance and education in the physicians and clinicians that are doing this. And so they actually said, we're good now. We don't have to look at this anymore. So that is good news. The key takeaways from the final rule, which came out in this past November for this year, 2026, was that they finalized the conversion factor at $33.40. And they touted, of course, that this was a 3.4% increase from the 2025 conversion factor. But as I already told you, it's actually a 1.5% decrease from the 2023 conversion factor of $33.88. So it's kind of bad news masquerading in good news. And the code that came out a couple years ago, G2211, and we'll talk about it a little more later on, it was finalized by Congress. It may have been overestimated. What does that mean? CMS sometimes is actually predicting the future, or they think that they're predicting the future. And what they did is when it came out in 2024, they said that they expected the utilization of G2211 to be a certain number. And they took that number and they removed it from the conversion factor. So one of the reasons the conversion factor went down for the last 2 years was because of this code, G2211. It was supposed to happen a certain number of times, but after AMA has done some evaluations, they believe that it's been overestimated in its utilization by sixfold. So 6 times as many claims was predicted by CMS than actually happened. So we're paying a lot for this G2211 that's not even taking into account its utilization correctly. These are the impact tables that you can download from the AAD website. It's not really important that you be able to read these, although they do look pretty large in the view that I'm seeing right now. There are 2 numbers on the right, at the very right column, which is the difference between 2025 and 2026. There's a light blue line and there's a gray line. Don't for most of you, the gray line is not going to be applicable. It is actually the facility fee schedule, which is different than the physician fee schedule. The academic centers out there, if you work for an academic center, these are real numbers. And if you look at these numbers, it's pretty significant, right? They're basically taking cuts anywhere between 13 and 15% in a lot of the codes that dermatologists do. The good news is that the physician fee schedule went in the opposite direction. It went up a little bit. You can see in some lines that there's a 2 or a 3. And if I go to the next slide, you can see the E&M codes, which start to take place in the middle of the table. there is an even larger increase in the fee schedule. We're looking at anywhere between 8 to 10% increases in the E&M codes for this year. And that's important because one of the ways that you can increase your revenue is actually to do more E&Ms if they're appropriate. And it's really important this year to start paying attention to the AMA grid with the complexities and the column one and column three as we know them, the way to get to a moderate complexity level visit, which is what you need to use a level four visit. And the reason it's more important than ever is because there is an automatic downcoding that is starting to occur quite frequently by insurers, especially the commercial insurers, that are basically taking our claim where there's a level four visit and downcoding it to a level three. And this is not as easy to spot as you might think, because if you're getting denied a claim, it's easy to see when you get paid zero on your EOBs. It's not as easy to see that you got paid for a code, but you didn't get paid the right amount for the code. And that's something you have to look for, because if your codes have been downcoded, if your E&M codes have been automatically downcoded, there is an appeal process and you should go through it. You should appeal every claim that's denied or that's downcoded and send in your notes. And that's why I'm telling you to pay more attention to the complexities now, because we're going to be sending in a lot more office notes in order to justify the use of higher codes when we bill for E&Ms. It's a very important concept. There are some changes in the CPT book in 2026. The word acne surgery no longer appears in the book, but the code is still there, the 10040. It is now under the incision and drainage section, and it is actually now considered to be an extraction code. And it's marsupialization, opening of or removal of multiple milia, comedone, cysts, and pustules. But the reason for this is there were a lot of clinicians who were coding this and were using other methodologies to code for the acne surgery code, such as like a chemical peel. And this change in language is to indicate that nothing short of an extraction of a cyst or a milia or a comedone, unless you're extracting it, you can't use this code. Okay, so if you are extracting it, you can use the code, but if there's no extraction taking place, you cannot. There were significant changes for superficial radiation therapy in 2026. There's a whole list of new codes. The one that's really important to see is the 77439, which allows for image guidance, but the image guidance is only allowed once during the course of treatment, not per fraction, but per course. So if you're seeing the patient for 18 fractions, you can use this code once out of those 18 visits, no more than that. And the other codes were replaced with new codes, and the reimbursements were adjusted for these codes as well. So if you do superficial radiation therapy, you need to know that the codes are completely different starting last month in January. Skin substitutes. If any of you are using skin substitutes, they were hammered in the final rule last year. They were all paying very high amounts. They were reimbursing at a very high level. And what CMS did, at least for the moment, is actually take down that level and level set it so that it pays the same amount regardless of which skin substitute you use. So it doesn't matter anymore which skin substitute you're using. The reimbursement for any of the skin substitutes will be about $127 per square centimeter. And you have to be completely aware of that if you're buying skin substitutes from a company, to know what the cost is versus the reimbursement, because they were very expensive until now, and now they're going to have to be a lot lower in price in order to make this a viable procedure, which it can be for patients who have large wounds. This can be a very effective way to treat them. So with excuse me, with all the bad news, what can we do? And what I've been trying to tell dermatology practices across the country is that there are codes out there that you're not used to using that you should become used to using. The G2211, remember we talked about that earlier. What is it and when can I use it? Well, basically, it indicates that you are the quarterback of your patient's care for that diagnosis, right? So you can read the definition. It calls it the focal point for all needed healthcare services. But if you are, say, in an atopic patient, you are going to direct the care. You're going to be the one to prescribe their biologic if they need it, and you're going to get outside referrals. You're going to refer them to outside physicians because of their atopic dermatitis. Then you are the focal point or the quarterback of that diagnosis, and you should be using G2211 when you can. Now, G2211 is not a CPT code. It's technically a HCPCS code, which is actually a fancy way of saying it's a CMS code. CMS created this code. They then over predicted what its utilization was going to be. And now we are all paying for it through the nose. So my attitude is if we've already paid for it and we're paying a lot for it, you should at the very least use it when you can in order to make up for this. So it is now at this point mostly only covered by Medicare or other government services. And the problem with it in dermatology is when you can't use it. And the problem, besides being a time limited relationship with the patient, is that when you put a modifier 25 on your claim, it disallows this code to be used. So this can only be used in patients where an E&M is used alone and not with a procedure. Because once you do the procedure, you can no longer use this code. Okay. And then, as a broader view, I would tell you to start looking outside the physician fee schedule completely, because we all tend to really focus on those 20 CPT codes world that we live in. And we don't understand that there are other ways to um, legitimately and ethically collect revenue into the practice that is not associated with something that we were necessarily trained to do as residents. And one of those things is basically what hospitals have been doing for a long time is they have the 340B drug pricing program, which is where they get medications on pennies for the dollar that they can then bill to the insurance company. There are facility fees that if you work within a facility, you can collect as well. But then there are J codes. Excuse me. Then there are J codes, and J codes are really they're medications. And if a drug has a J code, you can do what's known in healthcare as buy and bill. And buy and bill is actually a very good way to increase revenue into the practice if you do it well. And you have to do it well, because if you don't, you're going to get burned. And this is that's really the main limitation of buy and bill, is that you need the infrastructure to do this right. What you're going to do is you're going to basically take this service, which is a patient getting an injection. And there are a couple of rules that are pretty basic to this. Number one, it has to be approved for in-office injection. The poster child for this has always been tildrakizumab, which is a biologic for psoriasis. What this does when you do it is it actually takes it out of the, if you're doing it for a Medicare patient, it takes it out of Part D or their pharmaceutical insurance, and it makes it a medical service, which is Part B. Now, this happens also if you do it for a commercial insurer. It also takes it out of the pharmaceutical benefit, and it makes it a medical benefit. So what that does is If you think about a Medicare patient in specific, is it really is a means of access for your Medicare population, because your Medicare patients cannot use those cards, those discount cards that are given by the insurance by the pharma companies to be able to get access to their drugs for self injection. That cannot be used by someone who has a government insurance. So with a Medicare patient, you actually remove it from a pharmaceutical benefit and you make it a medical benefit. And medical benefits are the same thing as your office visits and procedures, your biopsies for a Medicare patient. It's the same split, the 80/20. And what you can do with this is you can take the average sales price, add 6% to it, and bill that to Medicare. Now, the paradox of having such high priced drugs that we have is that 6% of a very high priced drug is impactful and it can be meaningful to your practice. And there's also a CPT code for the injection that is an additional procedure that you can code for. And just to finish up on buy and bill, it is really important to get it right. And like I said, infrastructure, if you've just got one person up front and one person in the back, you might not want to start dealing with drugs that cost north of $15,000 because you really have to keep track of these medications in order to do it right. And so infrastructure is really important. And perhaps there may even be ways to outsource that infrastructure in the near future. So getting back to what happened yesterday, the president signed a bill, a budget bill that contained some important telehealth provisions that I just want to go over with you, because this is just basically as of yesterday. The flexibilities that we have been living under since COVID, the COVID relaxations of telehealth, have been now extended until January 2028, which is good news because it kept on getting kicked. It was going to be another 6 months and another 6 months. Now at least they've lengthened it to 2 years. Excuse me. My guess is that within these 2 years, there will be a bill that makes these relaxations and flexibilities permanent. But until that happens, you have until December 31 of 2027 to use the same rules that we were using since COVID initiated these flexibilities. And those are the geographic and originating site flexibilities. So it doesn't matter where your patient is. It doesn't, it used to be that you could only use the telehealth codes if you were in a clinic. Those are no longer necessary. These are a continuation of those flexibilities. So you can see a patient anywhere in the world, regardless of your licensing in a state. You can see a patient from your home on telehealth, and those are all acceptable. And Medicare beneficiaries can continue to receive those services in any location through the end of December 27. And their provision for audio-only telehealth can also be provided continuing through December 31, 2027. And basically, some of you may have a question as to whether you need to bill the office visit or the telehealth visit. For Medicare patients, it's still mostly the office visits because Medicare, I think, only accepted 2 out of the 16 telehealth codes that were passed by CPT and RUC. And so basically, you're using the E&M codes for your Medicare patients. And for the commercials, some of them accept the E&M codes. Some of them require the telehealth codes. You just have to use trial and error to figure out which ones to use for each insurer. And I think with that, I am going to open this up for Q&A. I'm also going to leave this up there. That's my email address. If you don't have the time to type it in or you think of a question afterwards, please feel free to email me that question and I'll try and get to it. So Allison, I don't know if you have some housekeeping announcements you want to make before we start.
Yeah, no, I was just going to actually direct people. If you don't see the Q&A, it's a little box. It should pop up at the very bottom. That way you can submit your question, and we'll try to get through as many of them as we can. And Dr. Kaufman, are you able to see them on your side?
Yes, I am.
Okay. Yeah, I think I will hand it over to you to answer some questions that you feel that we can definitely get to tonight.
Okay, sure. So the first question is a rather long one, but it's mostly about cloning. And cloning is a big deal for auditors for any insurance company. They one of the outgrowths of the EHR era is that a lot of notes look the same. Everyone likes to use templates, and templates can lead to cloning. And so it's really important to try and individualize the notes to the best of your ability when you're doing this. The irony is the next level of technology enhancements is actually going to go a long way to doing this for you. The AI scribes that many of you are hearing about now are actually going to potentially be the solution for the cloning problem. And the reason for that is that it's going to listen to your entire conversation with the patient. And so that's going to be an excellent way for you to include things that are important to educate the patient in, like benzoyl peroxide issues and other things written in the question. The way it's going to do it is it doesn't, it's not hurried, and even if you have a scribe, it's not going to forget what you said. It's going to remember it, and if it's medically pertinent, it's going to be good enough to keep it in your note, and that's going to really go a long way to personalizing notes. So if you ask me what my solution for cloning is, it is basically getting an AI scribe. As far as Medicare and Medicaid is concerned, can you comment on the safety of continuing to provide telemedicine as of February 1st? Okay, I think I answered that already. Yesterday, it was actually extended until the end of 2027. So there is no problem. I'm not, you were taking chances if you were doing it in the last couple of days, but yesterday just erased any problem there may have been. On the physician fee schedule slide, can you explain the difference between QP and non-QP providers? Um, I'm not sure. I will look that up and let you know. What constitutes serious or complex? Is that up to our interpretation? If giving topical steroids for atopic dermatitis, is that sufficient to bill G2211, or does it only apply when prescribing a biologic or immunosuppressant? It really, I mean, you can use, what type of medicines you prescribe as a criteria, but the truth is that we're flying by the seat of our pants. The definition by CMS is really to be the focal point of care. It doesn't it doesn't specify that you have to prescribe serious medications with serious side effects in order to use it. It just says that you have to be the focal point. So it's more really related to what your position is in the diagnosis that you're treating than it is in how you're treating it. You can make a case if you're basically the only physician who's treating this patient's atopic dermatitis, that you are the focal point, even if you're only giving a prescription for triamcinolone to the patient. So I think that that's really, it's more indicating that you are the focal point of care for that patient for that diagnosis. How often does insurance deny acne surgery? That's individual and regional, so I really can't comment on that. No more blackout states for telehealth, not until January 1, 2028. How to use a modifier 25. Well, that's a whole nother lecture in and of itself, but modifier 25 is when you perform a procedure the same day as an office visit, or you perform an office visit the same day as a procedure. And it really has to be significantly different from uh, what you're doing the procedure on. So, separate and identifiable is the language in the CPT book, and that's really what you have to consider when you're doing it. There are some um, real standalone exceptions to that. There are times when, according to CPT, you can use one diagnosis as per CPT. I'm not sure that you'll get paid, but if you want to get paid, you probably would need a second diagnosis. But there are situations, and the poster child example for that would be actinic keratosis, where you might freeze some hypertrophic actinic keratosis and then give a topical medicine or field treatment for their actinic keratoses. And the reason that that's still separate is because there are a lot of things that are included in a procedure, such as talking about the diagnosis. So if you were just counseling the patient on actinic keratoses, it wouldn't help. But prescribing a medication is not part of the procedure of destruction. So you could technically destroy an AK, a hypertrophic AK, prescribe, uh, your favorite 5FU recipe topically to use for a patient, and still be able to use a modifier 25. I don't know if you'll get paid for it, but you can do it. If they respect CPT, they'll allow it. If you really want to get paid for a modifier 25 office visit, you're probably better off having more than one diagnosis. What resources do you recommend to graduating residents to learn billing? It's really not easy, and there's some resources that are important. AAD has a manual that is really a sister book to the CPT manual, but the truth is that the AADs, what they do is they really take out the pertinent codes from the entire CPT book, which is daunting to read, and it actually goes through them with a dermatology point of view. So that's very helpful, and I would definitely get that. The other thing you can do is go to the lectures at the AAD meeting. There's always a ton of practice management and coding courses to take at AAD, and then there are also practice management meetings that are sponsored by various different organizations, including AAD and others. And I would recommend going to some of those. Okay. Can you talk a little more about G2211 and how it can be used in generating? Well, you use it by adding it to your claim. It has to actively be added to the claim in order to be paid by CMS, by Medicare. And so you add it. It depends on how you're doing this. If you're doing it by hand, then you just add it to the claim. If you're using an EHR, you have to find out from your EHR company how to get G2211 added uh, into as a plan. I mean, I know in our group we have a G2211 plan within Emma that we use that explains that we're the focal point of care for this patient for this diagnosis, and it populates the G2211 into our claim form. Do you know, this is a great question. Do you know when the sequestration is going to end? Yes, I'm pretty sure that everyone on this call will no longer be alive when sequestration ends. And the reason for that is quite simple. Uh, Ever since when sequestration was entered into legislation, I believe in 2011, to start in 2013, which it did. Sequestration is that 2% discount that you see taken on every Medicare EOB that you get back from CMS. And it was put in as basically a punishment to Congress, meaning that they spent too much. And so they have to actually take back 2% of certain things that they spend on. And one of those things was deemed to be physician payment. So they take back 2% of the physician fee schedule. It's another way that they take money away from us. And every time they've done us a favor and they've fixed the conversion factor and made it so that it didn't go down, guess what they did? They extended sequestration further. Sequestration was supposed to end in 2021. It is now scheduled to end in 2031. But my guess is that future fixes are going to extend sequestration even longer. And so I think we'll all be retired before sequestration is done, if it ever is. Is there an instance where insurances will automatically deny paying for subsequent E&M visits for the same diagnosis code within 90 days? Again, that's really an individual payer issue. It is certainly not a CPT problem. If you're seeing a patient back and you're not in a global period, then you should be able to do another E&M on them, even if it's within 90 days. If it's a specific uh, payer that you're having that problem with, then there are ways to reach out. There is a committee for AAD called the PAPER Committee, which is the Patient Access and Payer Relations Committee. They have an email address. It's privatepayer@aad.org. And if you're having an issue with a specific payer, I would definitely try and reach out to that committee and tell them what your problem is. With G2211 being overestimated for utilization, what future impact do you anticipate if the overestimation of utilization is corrected? Will reimbursements go up and/or any risk that G2211 will go away? I don't think G2211 will go away because it was CMS's idea. I can't imagine any world where reimbursements will go up for this. I think it's just a lesson learned that CMS probably shouldn't go into the predicting the future business. Do the telehealth codes provide the same RVUs as the traditional E&M codes? No, they do not. But as I talked about, you can use where the payer allows it, the E&M codes for telehealth. Please give examples to get a level 4. Also, way too much to do for this webinar, but there is a grid that the AMA puts out that has 3 columns in it. The first column is the complexity of the diagnosis. The second column, which isn't used that much by dermatologists, but we can, is the data column. And the third column is the disposition column, what you're doing for the patient that day. And probably the easiest example of a level 4 I can give you would be a patient who has a atopic dermatitis flare or a psoriasis flare. It is a chronic disease. They are flaring. And if you prescribe medication to treat that flare on that day, that in and of itself is a level 4 visit because you need to have a chronic exacerbation to get you, one of the ways to get you to a level 4 in the complexity. And you need to do prescription drug management in column 3. And you have to use 2 out of the 3 columns. It is a lecture in and of itself. And maybe that's a good idea for Derm Authority to think about doing an E&M coding lecture. Any info on what % of visits should be level 4 on average in a given day in medical dermatology? There is no data that's been put out by CMS as of yet. Those of you who use Modernizing Medicine can actually look at, you can find a way to look and see how your level 4s compare to, I think they do have some CMS data, I think from 21 or 22. But they also have national data from Modernizing Medicine users, and you can actually compare yourselves to that. I'd say from what I hear nationally, I'd say probably about 20 to 25%, even up to 30% of visits being level 4 is within the bell of what I'm hearing. CMS wants to diminish red tape. Why don't they get rid of MIPS? CMS creates red tape to try and get rid of red tape. That's probably why it will never happen. Okay. How would you code this encounter? Let's see if we can get this. The patient with hair loss is doing well on oral minoxidil. She comes in to see you and continue her medication. Is this a level 4? Would this fulfill medication management and count as a level 4, or would it be a level 3 because you didn't change meds? So this is so there are some people who probably think this is a level 4. I do not. I think prescription drug management is more than just e-prescribing a refill. Uh, and I actually was on a call today with some in my group where I told them, if you're thinking about this, how does it feel? Does it feel like you're actually educating the patient, changing their medication, increasing the medication, doing something active? Or do you feel like you're just refilling a medication and you're saying, you look great, let's continue on this, and I'll see you back in 2 months? If you're telling them the latter, I don't think that that's prescription drug management. I think that's drug refill management. And I don't think it's the same thing. That is my opinion. I am not telling you that my opinion is the only right one, but you got to be able to, you know, justify this if you're audited. And unless you're writing in your note that discussed with the patient, increasing the dose after discussing potential adverse events, the patient chose to stay on the same dose. That's a different story than just simply refilling their medication. And so, if there's rationale in there that shows that you actually managed the prescriptions, then I think you can get it to a level 4. If not, and I didn't even get to the point of discussing that hair loss um, may or may not be the complexity of a level 4, but I'll leave that for another day. What are some CPT codes that most dermatologists don't utilize? I would say probably the in-office injection codes are probably the ones that can help you the most. G2211 is another one. And we got to keep digging for more. There's also the sub-Q excision codes that you can use for excising lipomas. The shave removal codes are probably one of the most underutilized codes in dermatology, where everyone's just defaulting to skin biopsy instead of thinking about whether or not they were actually trying to remove a lesion, where you can use a shave removal code, which in 99% of cases will actually reimburse higher than a tangential biopsy does. Um, does the way you list diagnosis, prescriptions, and procedures in your note matter as far as reimbursement goes? It shouldn't, but we usually tell our clinicians to list the primary diagnosis first, to do that first. I'll often reorganize my note to have that diagnosis be the first one. I think it just works better that way. Uh, when you're performing a procedure, I didn't understand that one. Preventive codes for skin cancer screening. That's a great question. I wish it were true that you could use them, but you can't. And the reason is there is a U.S. task force that the government listens to who determines what diagnoses can be considered preventative, um, uh, or what conditions can be considered to use the preventative codes. And skin cancer screening, it has never been found to be significant enough to rise to that level. So skin cancer screening does not exist in the language of CMS or payers. It is a construct that we use, but it is not a valid screening visit. And so if you have it, you can't use it for that code. It will. I know a lot of patients come in and tell you that you can, but you're not supposed to, because it is not a valid screening for the government's purposes. Okay. What, if anything, can be done at the legislative level to level the playing field between private equity, corporate medicine, and private practice, specifically related to giving terrible contracts to private practices and giving better contracts to large corporate practices? We should all be paid the same for the same work. I don't disagree at all. I think everyone should be paid the same, but no one is. And I wouldn't assume that private equity is necessarily getting better rates than certain other private practices. There are regions which are known for being very aggressively stingy, no matter who you are. And there are ways to the best way to level the playing field is actually to be part of a uh, clinically integrated network or independent physician association with a hospital that can actually help to negotiate on your behalf. As dermatologists, we're already looked at askew by payers. And if you're in solo practice, which I was for 25 years, uh, it is almost impossible to get, first of all, to get on some of the plans and then to get decent reimbursements. Can a G2211 be added to procedures or only office visits? It cannot be attached to a procedure. In fact, if you do a procedure, the code will be denied automatically. It is only to be used with an office visit where the office visit is the only code that was used in that visit. When we say flare of a chronic illness, can that be synonymous a disease that is improving but not at goal and still allowed to get a level 4 if we prescribe something? So this is an important question. Do you have to be flaring to get a complexity, a moderate complexity, so that you can get a level 4? And the answer to the question is no. You can use not at treatment goal as your justification for using the moderate complexity. Now, here's the thing. You can say that your patient is not a treatment goal, but if you never delineated what the treatment goal was prior to that visit, you cannot say that they're not a treatment goal. So one of the things you should do early on in a diagnosis is actually lay out what the treatment goals are so that at future visits, if the patient is not flaring, but they're still not at their treatment goal that you determined together, then you can use that rationale and use the moderate complexity to get you to a level 4. Does In which cases can you use a shave removal code? Um, so you need to use a shave removal code when you are removing something. I know that sounds a little simplistic, but the shave removal code is based on your intent. What was your intent? Was your intent to determine whether or not something is a cancer and that's a biopsy? Or was your intent, patient comes in and says, this scaly lesion on their elbow, they keep hitting it when they put their arm down and it hurts. And then you remove it. And that's a shave removal because that was your intent. And you should put that language in your notes. Now, there are some people who think with a shave removal, you can't send that for histology. That is totally incorrect. Not only can you, but you should send it for histology. And at the same time, I wouldn't worry that you're concerned you didn't fully remove the lesion. I personally use the reasonable person test. If your patient thinks you removed it, then you removed it. If you get back if you get back something from the lab saying that the lesion still exists below the level of, within the dermis, it's still a shave removal because it's based on your intent. Now, uh, can you do, let's say you shave remove an irritated lesion thinking it might be an SK and it comes back as an SCC. Can you treat the SCC after a shave removal code? Yes, you can. The only it is agnostic to whether or not the lesion is benign or malignant. So that's why you can do that. And the last thing I want to say about it is try not to confuse an auditor with language. So if you are going to send the lesion, and I do recommend it, to the laboratory for pathologic examination, those are the words that you should use. You shouldn't say sending to the lab for biopsy. Why? Because an auditor is going to see that and say, well, it's a biopsy because you said you're sending it for biopsy. Never use the word biopsy in your note on a shave removal procedure. Say, if you want, that you're sending the specimen to the path lab for evaluation. I was told that shave removal required extension into the fat. No, that's false. Shave removal can go to fat if you think of the forearm of an elderly patient. If you shave remove something, you'll often get to fat. But no, fat is a requirement for an excision. It is not a requirement for a shave removal.
And Dr. Kaufman, sorry, I just want to jump into a quick time check. It's 8:56, so you probably have time for one or two more questions.
Okay. Uh, if you do a biopsy of a rash and also prescribe triamcinolone for it, are you able to bill both biopsy and E&M? So um, the truth is, it depends, right? If the rash is one area and you do a biopsy on it, anything you do after that is still work that is considered part and parcel of the procedure. So if the patient comes in and they have one small plaque on their forearm and you do a biopsy, then you can't bill for an E&M as well. The only way you can get that E&M is if you do all of your counseling that day and schedule the patient for a biopsy, or if there is another diagnosis that the patient has, that in addition to that lesion on their arm, they also have sebderm on their face, then you can bill for your E&M using the seborrheic dermatitis as the diagnosis for it. And take one more. Do you get paid more with one shave removal and one shave biopsy versus two shave biopsies completed at the same visit? You would have to do that if you do if you do one shave removal and one shave biopsy, you will be subject to the multiple procedure reduction. The tangential biopsy has an add-on code, which used to be favorable to the multiple procedure reduction. I think they've since corrected that, but you'd have to do that calculation on your own. Okay, Allison, I'll turn it back to you.
Thank you, Dr. Kaufman. I think everyone on this call, we just thank you so much for sharing your knowledge with us. I think this might have broke the number of Q&As I've seen in my history with Derm Authority doing webinars. So I appreciate you just your generosity answering all these questions. Everyone on this call, we do pass on the questions to Dr. Kaufman, and of course, he did share his contact info with you. But again, just thank you so much, Dr. Kaufman. This was so educational, and we appreciate everyone for being so engaged. So everyone on this call, stay tuned for more webinars like this moving forward, and we appreciate you joining us tonight.
Thank you, Allison. Thanks, everybody. Have a good night.